Welcome to Dr. Balga's podcast for the Curious Doc. Today is Feb 13, 2026. This video is on a Lancet article published online on Feb 6, 2026, titled Assessment of Adverse Effects Attributed to Statin Therapy in Product Labels, a meta-analysis of double-blind randomized controlled trials, published by the Cholesterol Treatment Trialist Collaboration, CTTC. There was an accompanying commentary in the Lancet published today and an editorial. The commentary was titled Product Labels Downplay the Safety of Statin Therapy, Evidence from Randomized Controlled Trials. And the Lancet editorial from the Lancet editors was titled Statin Safety When Warnings Outlive the Evidence. Statins, the benefits of statins. An effective statin regimen, such as atorvastatin, 40 milligrams once daily, given for 5 years to 10,000 individuals, would be expected to prevent major vascular events in roughly about 1,000 patients, an absolute reduction of about 10% among those who already have established occlusive vascular disease, and in about 500 patients, an absolute reduction of about 5% among high-risk individuals without prior events. The principal established adverse effects of statins is myopathy, which is rare, about 1 case per 10,000 person-years, and in more severe instances, rhabdomyolysis occurring in roughly 2 to 3 cases per 100,000 person-years, typically accompanied by muscle symptoms and marked elevations in creatine kinase. Statins are also associated with a small absolute increase in milder muscle symptoms, mostly of which arise during the first year of treatment. You can read more in this Lancet article published in 2022. You won't find a whole lot on muscle symptoms in this Lancet article. Diabetes. Statin therapy is linked to moderate dose-dependent rise in new-onset diabetes, occurring predominantly in individuals whose baseline glycemic measures are already near the diagnostic threshold at the time treatment begins. Again, the same authors published this in 2024. So more details about diabetes in this 2024 article, and it won't be seen in this recent article published this week in the Lancet. This trial looked at statin product labels that list multiple potential undesirable effects, largely derived from non-randomized or non-blinded studies. This meta-analysis assessed causal evidence using individual participant data from large double-blind randomized trials. The trials were eligible if they had greater than 1,000 participants, scheduled treatment for over 2 years. There were double-blind comparison of statin versus placebo, or more versus less intensive statin therapy. 19 placebo-controlled trials were included, which included 123,940 individuals. Median follow-up period 4.5 years, mean age 63 years, standard deviation 9. 72% were men, 48% had prior vascular disease, and 18% had diabetes. Additional trials assessed 4 intensity trials, 30,724 individuals, median follow-up 5 years, mean age 62 years. So there was a total of 154,064 participants across 23 trials. The statistics used was an intention to treat analysis, event rate ratios, RRs, with 95% confidence interval. False discovery rate was controlled at 5%. Of the 66 pre-specified undesirable outcomes, only 4 were false discovery rate significant. Abnormal liver transaminases 783 in the statin treated group versus 556 in the placebo group. So the ratio was 0.3% versus 0.22% per annum. Other liver function test abnormalities 651 in the statin treated group versus 518 in the placebo group. So the absolute annual excess was 0.13% for combined liver abnormality. Alteration in urine composition 556 in the statin group versus 472 in the placebo group. Edema 3,495 in the statin treated group versus 3,299 in the placebo group. Absolute excess for each was less than 0.1% per year. There was no significant excess for cognitive impairment, depression, sleep disturbance, sexual dysfunction, peripheral neuropathy, acute kidney injury, interstitial lung disease, or other hepatobiliary outcomes. Limitations: median follow-up was less than 5 years. There was heterogeneous event recording, limited power for very late effects, inability to assess severity or rechallenge effects. Key takeaway: beyond known muscle effects and diabetes risk, statins show only small biochemical changes with minimal absolute excess risk. The current product labels likely overstate the harms. So clinical pearls: myopathy and diabetes risks are established but modest in absolute terms. Liver enzyme elevations are small, dose-related, and rarely clinically significant. Most label-listed adverse effects lack causal support from blinded trials. Absolute excess risk for confirmed biochemical abnormalities are less than 0.1% per year. Improved evidence-based labeling may enhance adherence and prevent avoidable cardiovascular events. What does the accompanying commentary say? They say that persistent public concern regarding statin safety has been amplified by observational studies, media reports, and long lists of potential adverse effects in product labels. They discuss the findings of this study, 23 large double-blind randomized trials with over 154,664 participants. Only 4 of the 66 label-listed adverse outcomes were confirmed, primarily mild liver enzyme elevations, and no support for most of the other claimed harms. The nocebo effect: the blinded design helped to counter nocebo-docebo reactions, particularly relevant for muscle symptoms. The clinical significance: liver test abnormalities are small and not associated with clinical liver toxicity. Urinary changes and edema are of uncertain clinical relevance. The public health message from this commentary: statins remain very safe. Drug labeling should be revised to reflect randomized evidence and improve adherence and cardiovascular outcomes. The editorial talks about the implementation gap. Despite over 30 years of evidence, statins remain underutilized worldwide due to largely persistent safety fears and extensive product label warnings. Best evidence: double-blind randomized trials confirm only established risks, muscle symptoms, and rarely myopathy, modest diabetes increase, small liver enzyme elevations, and minor urinary changes and edema of uncertain relevance. Evidentiary imbalance: harms can be added to labels based on weak observational signals and persist without systematic reappraisal, distorting risk perception. Regulatory reform: the editorial says the label should distinguish provisional safety signals from causally established harms, including absolute risks, and undergo scheduled evidence-based review. Public health imperative: statin underuse leads to preventable myocardial infarction, stroke, disability, and health system costs. Risk communication must reflect trial evidence. So these three articles in Lancet are fascinating, open access. You all must go ahead and read it. Full disclosure, I wrote the statin prescribing guide for Oxford University Press many moons ago and co-edited the Dyslipidemia Handbook, also by Oxford American University Press, which I co-edited with Dr. Christopher Cannon from Harvard Medical School and the Brigham. Podcast brought to you by masterbedfacts.com. This podcast is for physicians and healthcare providers. If you enjoyed this video, please like, subscribe, and forward to your friends.